Welcome to the TechLink Health Podcast, an on-demand source for the top trending healthcare topics and insights. Delivered by key opinion and emerging leaders and as featured on the TechLink Health app. The healthcare industry is rapidly evolving, so our goal is to connect listeners to the most relevant insights, ranging from digital health to financial well-being to interesting side gigs. For more details, visit www.techlink.health.
Hello, everybody. Welcome back to the TechLink Health Podcast. I'm Justine Reese, and today's episode, we are focusing on the role pharmacists play in the broader healthcare ecosystem and how this role will continue to evolve in shaping the future of health and longevity. This episode's guest is Kaylee Mehlman. She is a board-certified geriatric pharmacist and senior care consultant, and you can't see her, but I can. And my question that I'm going to ask soon is, she's so young, and I'm curious how she ended up being a geriatric pharmacist and senior care consultant. And I can't wait to hear that story. But her mission is strongly tied to creating a healthier future through collaborative efforts to connect the dots in the broader pharmaceutical community. Kaylee holds a Doctor of Pharmacy from Ohio Northern University, and throughout her professional journey, she's advocated for pharmapreneurship. I love that word, pharmapreneurship. Did we make that up, Kaylee?
I think you did, but
Okay.
Let's go with it.
Let's go with
I'm
it.
sure
I like
there's somebody out there who's coined that, but
I
it was
think
news
it's real
to
good.
me.
It's really good. So I'm going to say it again. I liked it so much. She's advocated for pharmapreneurship and is a member of the American Society of Consultant Pharmacists. So it goes without saying, Kaylee has a passion for expanding the curve of traditional pharmacy, and we look forward to getting her perspective. So without further delay, we are very excited to have you, Kaylee, on the podcast, and thank you so much for joining us today.
Yeah, absolutely. Thank you for having me.
I guess tell us your journey into pharmapreneurship. Let's get right into it. What brought you to become a pharmacist and start doing this?
Oh my goodness. So when I prepped for this, I just started typing, just trying to flesh it all out, right? And I think I could go on for a really long time, but I'll try to keep it succinct for our listeners. And so I was fortunate enough to know that I wanted to be a pharmacist fairly early on, which was really beneficial for me because at the time, this is a whole topic for another conversation, but there's been a lot more pharmacy schools opening up in the United States. So when I was applying to pharmacy school, there were 4 schools in the state of Ohio, and there's now 7. So there were much, much less seats for potential pharmacists. So I was fortunate enough to know early on that I wanted to be a pharmacist. I loved chemistry. My cousin was a pharmacist. You're a young adolescent just trying to figure out, what you want to do with your life. And it just seemed like a perfect fit. My mother was in healthcare, so I kind of had the healthcare background. And I just thought that this was just a good fit for me. So that's kind of where we went from there. But yeah, so knowing early on I wanted to be a pharmacist, I got to visit the 4 colleges of pharmacy and get my exploring in and figure out where I wanted to go. And I ended up going to Ohio Northern University, which you mentioned, which is in another small town in Northwest Ohio, which I was dead set on, being a big city girl in college, but it didn't pan out that way. I fell in love with the college and the campus. So one of the benefits of Ohio Northern was that it was a 0 to 6 pharmacy program, meaning that once you're accepted, you're in pharmacy school from day one. So you're taking pharmacy classes all throughout your 6 years there. The big catch is if you decide third year that, maybe you don't want to be a pharmacist, you don't end up with that bachelor's degree that you could fall back on. There's no straight path to a bachelor's degree if you decide to change course. So
Got it.
It's high risk, but I was fortunate enough to know what I wanted to do. So while I was in school, I was looking for an internship and mentioning that I grew up in a very small town in Northwest Ohio. The CVS, the Rite Aid, the local mom and pop pharmacies, they already had their interns and they didn't really need anybody. And someone said to me, that pole barn in the field is a pharmacy. And I said,
Pole
what?
barn in the field?
Yep.
Wow. Okay.
So I drove by. It's a very discreet building, which I'll get into in a minute as to why. But I drove by. Sure enough, it was labeled as a long-term care pharmacy. and they were needing interns, and I got an internship there, and I had no idea that this aspect of pharmacy even existed. So I've got to give my credit to Institutional Care Pharmacy, shout out, in Tiffin, Ohio. But the reason that these buildings are so large and they're discrete is that, I mean, you're dispensing volumes and volumes and volumes of prescriptions for nursing homes. Essentially, there's assisted livings and other things in there as well. But I remember they said to me, we have the largest narcotic inventory in all the surrounding counties. So we like to keep everything discreet because we wouldn't want to advertise that we're this giant pharmacy, right? Makes sense. But through all of that, I worked in dispensing, which was the physical dispensing of medications. I compounded things. I made IVs. I did all of that. And that's where I learned about this consultant pharmacist role.
Right, because we
So,
do want to talk about how you got into that. So yeah, let's talk about
yeah,
that.
yeah. So, what a consultant pharmacist is, and I noted when I was prepping for this that I kind of skipped over that, assuming
That people would just know.
I just forget sometimes that it's this really weird niche portion of pharmacy. So, a little bit of background is there's a federal mandate. It's unfunded, but there is a federal mandate that a pharmacist review a patient's chart once a month when they reside in a long-term care facility or a nursing home. So it's up to the nursing homes to either hire a pharmacist themselves to review those charts or collaborate with the dispensing pharmacy to provide those consultant pharmacy services. Now, there are some states like New Jersey that make you separate that church and state, if that makes sense. So you have to have an independent consultant pharmacist, and that your consultant pharmacist for your long-term care facility cannot work for dispensing pharmacy, because the goal of senior care pharmacy in general, at least how I practice, is to get rid of all these unnecessary medications, right? We want to get our elderly off of these medications that could affect their cognition, impact falls, things like that. The number one reason for emergency department admission is medication misadventures, which I'll get into later when we talk about tech and things like that. So you could see how if a consultant pharmacist worked for the dispensing pharmacy, it could almost be viewed as a conflict of interest, whereas why would we want to get rid of all these medications when that's how we make our money? And I'm not saying that consultant pharmacists operate that way. I'm just letting the listeners know that there is that school of thought that, that could be considered inappropriate. And some states are moving away from employed consultant pharmacists from the pharmacy providing those long-term care reviews.
And then as a consulting pharmacist, do you mostly work with the healthcare workers and the caretakers at the facility, or do you get to work with the patients and the residents? I guess they're not necessarily patients, they're
Yeah, the
residents.
resident. Nice
And
nomenclature.
hey, thank
Good,
you.
good job. Yeah, because in long-term care, we do call them residents as opposed to patients. And my answer to that is just, we could talk for hours and hours on this, but unfortunately right now, because this requirement is unfunded, there tends to be a quantity over quality model that exists simply because people are trying to get these done and they don't necessarily have the time to go sit down and speak with the patients or spend time with the patients, which is what I would prefer to do. But the current practice model just sometimes doesn't allow for that. So a lot of the information that you are getting is from the facility staff, maybe some family members if they're in the facility at the time that you're in there. There's been a big transition with the pandemic because a lot of us have transitioned to working remotely, because when all of these COVID restrictions came down, mostly consultant pharmacists reviewed as non-essential healthcare providers.
Well, also, so
So
much of that was happening in the beginning of the pandemic was through elderly care facilities. And they probably wanted to keep as little
absolutely.
traffic, in and out of those places. I was going to ask you about that, but you already kind of answered it, which brings us to some of the tech stuff. But before we go there, you've talked a little bit about collaborative efforts as you came up in pharmacy. But with the broader pharmacist community, as a parent with your involvement with the National Organization of Pharmacists and the American Society of Consultant Pharmacists, how can such collaborative efforts be scaled on a global level?
That's so interesting because I had to do some pondering and some research myself, honestly. What I will tell you is that the American Society of Consultant Pharmacists is in all 50 states and Puerto Rico and 12 countries. I don't have the list of those 12 countries, but I know that Canada bordering the United States is one of those countries. And one of the things that I found interesting, and just thinking about how we here in the United States handle healthcare versus a social healthcare model, is the different role that pharmacists play in those different healthcare models. So in the United States right now, pharmacists are not considered providers. We do not have provider status, which means that we cannot bill insurance for our services. So I'm seeing the look of surprise on your face, and
Well,
everyone is always very surprised.
yeah, I mean, it sort of does make sense. I'm just thinking about as an end user and what we use insurance for, and to get your pharmaceutical medications. But I guess it does make sense that it's a different category. So insurance is confusing anyway for us in the United States. So overall,
Absolutely. We every pharmacy association across the United States there's been multiple bills introduced to Congress. And I know we with ASCP, before all of this happened, we go to Capitol Hill and we lobby and we try to get provider status recognized. And for anyone on the call that's listening, the CBO score for pharmacist provider status is 9 million, which in the relative spending of things doesn't seem like a whole lot, right? And I have other stats too that I can dispel later. But coming back to what were we were talking about global. Okay, let's go to global before we go to tech, because when the tech stuff comes in, that's when provider status is going to be very important. So globally though, I kind of did some research. I kind of did some digging on does the senior care pharmacy niche and other pharmacists kind of take this globally. I looked at the World Health Organization. I thought, you know what, let's just go with the one we all know of, the World Health Organization. And they have a lot of different units. Units is the nomenclature that they use to break down how they address different things. And I found one called Aging and Health. And I thought that was really interesting. So I clicked on the Aging and Health unit link on the WHO's website. And it discusses the long-term care continuum. It educates a lot about long-term care. And I thought, I'm going to click on the staff link of the team members that are part of this. And lo and behold, they're all physicians. There's not one pharmacist on the team. Now, I can't say that for their other units. They have access to medications and health products that I did click on, and there were pharmacists on that team. But I thought it was really interesting that there weren't any pharmacists on the aging and health unit, specifically because we know how much medications can negatively impact our seniors' quality of life. I mentioned hospital admissions, things of that nature. So there's some initiatives, at least in the United States, and I know of in Canada as well, to deprescribe medications. So that the deprescribing means eliminating those medications that are maybe no longer needed based on your prognosis. Are you becoming palliative? Do we really need to continue the medication for your cholesterol? Things like that. That process of eliminating medications that are no longer needed is coined as deprescribing. So I know that there's initiatives both nationally and globally to deprescribe, but it wasn't reflected in the World Health Organization, which I thought was really interesting.
how is that sort of monitored on a global level in terms of, do you see trends in certain prescriptions that just really don't benefit them anymore?
Yeah, absolutely. There's a whole list of different types of guidelines, different types of recommendations that exist. The big one that's well known is called the Beers criteria. It's much less fun than it sounds. It's not about beer at all.
Sounded great. Head
It's
over to the
Dr.
Stein.
Beers.
Okay. Dr.
It's
Beers.
Dr. Beers, and there is a lot of experts that come together and discuss medications that are potentially inappropriate medications for our older adults. So basically, this list is updated every 2 to 3 to 5 years, depending, and it lists medications that we should, address with caution in our elderly population to say, is it still providing benefit? Do the benefits outweigh the risk? Is this something we should be continuing? There's also lists such as the stop-start criteria. The American Geriatric Society has the Choosing Wisely campaign. And recently there's been a large effort to try to decrease anticholinergic burden. That would be things like Benadryl. Maybe we have an elderly person taking some diphenhydramine for sleep. The anticholinergic effects of that can affect their cognition. They can present like they maybe have dementia. And it could be something as simple as we replace your Tylenol PM with something else for sleep. So there's a lot that goes into it for sure.
This always makes me think about the rising cost of healthcare and accessibility, both nationally and globally. So one aspect of this is the increasing popularity of sourcing drugs from abroad. And when you think about the future of healthcare with regards to the quality of treatment and the cost, what are your thoughts on sourcing drugs from abroad?
How long do we have, Justine?
Yes, I don't know. It seems like a big
It's
one.
it's a very loaded question, and I think for the listeners that have listened to some of the other podcasts on this platform, the most recent one that I listened to was a man named Prantik, I believe is how you say his name. His was excellent, and I'll just start by referencing what he was saying about focusing on preventive medicine to start with. Because when I think of how we as a country do budget reconciliation, we look at the things that cost the most money and we say, how do we decrease the cost of that, right? We have a hard tangible value of it costs X amount of dollars. How do we decrease the cost of medications in general? And the push has been to maybe source those from other countries. So first, there are two books that are fantastic on this. Both of the authors have been keynote speakers at some of the American Society of Consultant Pharmacists annual meetings. The first one is called China RX, Exposing the Risk of America's Dependence on China for Medication by Rosemary Gibson. And the second one's called Bottle of Lies by Catherine Eban. And so basically, for those that don't necessarily know how our global supply chain of medications work, there's the big countries responsible for a large majority of generic medication manufacturing. What's interesting is that there's very little regulation that goes into those generic medications. We think when we get our generic medications that someone has tested that medication, what's in that medication is what it says on the bottle, and that is absolutely not the case. There are pharmacies across the country creeping up. I myself have transitioned to one that test every single lot number and batch to see if there are carcinogens or other things in there. It's interesting if you read the books or listen to podcasts about the books or interviews with the author. It can be really, really difficult to even trace the supply chain of where a lot of these came from. So basically what happens is the larger chains, even the mom and pop places, order from these large wholesale distributors. So the wholesale distributors get them from other sources as well. And by the time it all trickles down, it can be very hard to tell where they came from, trace the manufacturing practices, things of that nature. And so as the consumer, that's why as a consumer, I personally switched to get all of my medications from this specific pharmacy that does test for the active ingredient and other excipients that maybe we don't want in there, just to make sure that what I'm taking is what I am taking.
Are there certain questions that we could ask of our pharmacists to double check those things?
They can tell you who the generic manufacturer is, and that's readily available on the bottle. But as far as your pharmacist in your drugstore then being able to trace that to a specific batch number, to all of that, we're all just kind of victims of the system.
Interesting. All right.
Yeah.
Well, food for thought, so to
Food for
speak.
thought for
Uh,
sure. And I'll take that one step further for you.
okay.
So if we think of something, let's say not as important, but is still important as vitamin C or ascorbic acid. China is the sole producer of vitamins in the world. So any vitamin C that you buy, if you buy it from Whole Foods and you think it's extra fancy, if you buy it wherever, it's all the same vitamin C coming from China. Now, if we take that and we think about medications that we need to sustain life, such as antibiotics, insulin, things like that, and we think about some of the geopolitical issues that are currently facing us and supply chain issues that are currently facing us, what would happen if we could not import those medications that we needed to import? I will say that when the pandemic happened, we discussed a national stockpile of PPE and resources and that. I think it's vitally important that we are able to produce these life-saving medications within our borders if in fact something like this would happen.
Yes, I would love to hear if you can give me sort of an encapsulated answer of how you felt the pandemic affected the pharmacy world that you were living in, particularly dealing with elderly care, as vaccines were coming out, as they were some of the first recipients of the vaccine. What was going on?
So the vaccine, if I'm going to be silver lining, Kaylee, as I get deemed by some of my friends, I always seem to find the positive in
I
everything.
don't think that's a bad thing. I think that's a great thing.
It's a coping mechanism. It's fine.
Yeah.
Another podcast for
Hmm.
another day.
Yeah.
Um, but the need to mass distribute vaccinations across the United States really brought to light how much we need pharmacists' involvement in this process. So the original plan was for the big chain pharmacies, Rite Aid, CVS, Walgreens, to distribute all of the vaccines to all of the nursing homes. And this was going to be a supply chain that didn't already exist. We were going to have to build this from the ground up and figure out how we were going to deliver this. And what the American Society of Consultant Pharmacists did through our advocacy at the national level said, hold on a minute. We deliver flu vaccines to nursing homes every single year. We deliver pneumococcal vaccines to nursing homes every single year. This is no different. We need to utilize our distribution chains and our supply chains that are currently in place. So because of ASCP's advocacy, we got those COVID vaccines to be distributed to the long-term care pharmacies across the United States to be delivered via the channels that are already in place, which I think really helped us expedite this process for our residents, because even that process was definitely chaotic and it was not done homogeneously across the states. In Ohio, it was really great. The Department of Health kind of headed all of it and distributed everything equally. There wasn't a whole lot of differentiation and allocation. But some of the other states kind of struggled when there wasn't, a particularly well thought out plan as to how all this was going to be distributed. So yeah, I think the pandemic was time for pharmacists to shine with regard to those vaccinations, because there was the question of how are we going to get all these shots in arms, and that's what we do. So it really brought us to the forefront of the stage.
And there's got to be a learning curve. I mean, obviously, when you're dealing with something this brand new, the next pandemic will have it down, Kaylee.
Right
Uh,
when right when it's we can all just forget about it.
exactly. So let's talk about the digital and technology perspective, especially with dealing with your focus on an aging population and senior care. Now, I understand you're not necessarily dealing with the seniors themselves, but there's another learning curve. What technologies are going to shape this space, and what role are you playing as a pharmacist and your cohorts with that? What's coming and what's here now that wasn't here a year ago?
So I don't know that I can quantify it within the past year.
Well, that's probably
However,
too soon, but 5
yeah,
years, let's say. Yeah.
what we can
5 years before
anticipate though.
before everyone knew what Zoom was,
Right,
right?
right. So I have about 15 bullet points on this. So I'm gonna keep it concise. So what's coming? The baby boomers, which we can call the silver tsunami, as it's called. So what we might also not know, the listeners might not know, is there is a finite number of long-term care beds in the country. So they can't just build more nursing homes. They can build more assisted livings. They can build more independent livings. We can't build more nursing homes because there is a finite number of long-term care beds. So what that means is that where maybe grandpa who had just a hard time dressing in the morning would go to a nursing home just for help with his activities of daily living, he's not going to get that nursing home bed anymore. We have a lot younger, a lot more ill patients requiring a lot more intensive care. So those patients they're going to be younger, they're going to be older, they're going to be just more ill in general. So what that's going to do is drive us to really try to age in place, because not everyone can afford assisted living, because we know that, once you get to a nursing home, you can apply for Medicaid, and Medicaid will cover the cost of that. But assisted living and independent living is up to us with our liquid assets to pay for.
When you say up to us, up to government, up to the individual to prepare for that
Up
moment?
to individuals. So if that assisted living facility costs $5,000 a month, then you are paying $5,000 a month until you no longer have any assets, at which point you would qualify for Medicaid, and then you could possibly be admitted to a nursing home.
So to prepare for that, what age do you think people should start thinking about long-term care?
This is another topic for another podcast. Definitely consult your financial advisor. There's a lot of different things that can be done as far as asset management, like putting all of your assets into a trust I think the number's now 7 years before you would then have to go into a nursing home, because what you can do is you can put your assets in a trust, and then if it's 7 years before you go into the nursing home, Medicaid can't touch those assets. So that's a way to protect those. There is long-term care insurance. Again, a financial advisor or an elder law attorney would
Right.
be
We
able
don't need
to.
to go down. We don't need to go down that rabbit hole. But
No.
let's get back to the tech. The
The
tech
tech.
subject
So,
line.
yes. So, with us all working to try to help everyone age in place at home safely, we're going to need digital healthcare platforms where we have access to pharmacists. And something that I see that's going to become increasingly utilized is wearables. So, the Apple Watch can tell your blood oxygen saturation, it can tell your heart rate. The newest one can tell if you've fallen, things like that. I see a great prospect here in utilizing those wearables for remote patient monitoring. Additionally, probably a couple months ago, I came down with an illness and I wasn't sure if it was COVID. So, being here in Cleveland, I downloaded the Cleveland Clinic app, and there you can request a virtual visit and you can get a nurse practitioner, a physician's assistant, a physician right there on the other end of your phone. What there's not a push button for is your pharmacist. So if we think of how overwhelmed our pharmacists in maybe Walgreens, CVS, those type of large chain pharmacies are, the Ohio Board of Pharmacy just issued a survey on pharmacists' workload, and it's public domain. And you can go and read everyone's comments on just how overworked pharmacists in the retail setting are, and how scary it is for patient safety, because there are so many metrics put in place. You have to check so many prescriptions per hour. Everything is just tied to metrics. And so those pharmacists don't always have the time to give you the valuable information that you need. Again, circling back to emergency room admissions and medication misadventures being the primary reason, if Cleveland Clinic had a button that said, talk to your pharmacist, ask a medication question, how convenient would that be? That then ties back into the fact that we cannot bill for our services. So there is no billing code for us consulting with that patient, possibly saving a hospital admission, right? So it's all intertwined. But I think there's going to be a huge, huge need for this, especially with the advent of all the at-home testings of various modalities. So you can prick your finger and send it off to see if your thyroid's functioning correctly. You can take an at-home COVID test. You can probably take an at-home flu test. You can check your blood sugar and see what's going on there.
Well, maybe the TechLink Health app can help bridge this gap to help pharmacists out. This is the perfect platform for that.
I think so. I really do. A pharmacist at your fingertips, right? So that's great that we're now sending out all these at-home COVID tests. But when someone has a question on how to interpret it or how to treat the symptoms, where are they going to go? They're going to go to their pharmacy, to their pharmacist who's already overwhelmed, who can't bill for the consultation and seeing the patient and advising them which over-the-counter medications to take and things like that. So there's a lot of work to be done, both legislatively and technologically.
Yeah, well, that's hopefully coming around by people like you bringing it to the forefront and making people aware of what is needed. So, wow, we covered just so many things. Did we talk about the raising cost of healthcare and pharmacy, maybe what's covered and what's not? I mean, I know I've gone in to get prescriptions filled and been like, I'm sorry, what? And then, of course, you're like, give me the generic brand and I don't care what's in it. Just give it to me. It's supposed to do the same thing, you know?
Absolutely. So that is also a larger discussion, actually another legislative topic, and that is regarding pharmacy benefit managers. So when you get your health insurance, you get your medical health insurance card, and there's either a PBM listed on there. So insurance companies will hire a third-party pharmacist benefit manager to do exactly that, to manage the pharmacy benefits for their lives. Okay, so then what those pharmacy benefit managers do, they have a lot of strings they can pull, which is increasing cost of medications. There's things called DIR fees or clawbacks that even after the pharmacy dispenses the medication to you, you pay for it. They can come back after the fact and take that reimbursement back. There's not a whole lot of money to be made at the pharmacy counter. You're lucky if you break even, which is why we've seen this national trend of the mom and pop places that you so much love to go to, that everyone really loved, we've seen those kind of evaporate, right?
Oh, yeah. I don't even know if I mentioned this, but the one that I was talking about went to for years. It closed and I was just broken. I'm wondering if, just like in so many industries, it's hard to get people to do what you do. Are we schooling a whole new generation of pharmacists that can work in the way that we need? What's happening there?
So back in, I don't remember specifically which year it was, so don't quote me, but there was a time when to have a degree in pharmacy, you just needed a bachelor's of science in pharmacy. It then transitioned to everyone had to get this doctor of pharmacy, which really what that entailed was everyone wrote a year of clinical experience before graduating. So every pharmacist that graduates today has that clinical experience and also wants to utilize that clinical experience. So with regard to the training of pharmacists to utilize this clinical expertise, we are the most underutilized, overtrained healthcare profession in the United States. We go to school to study pharmacy, and we are so underutilized because we do not have provider status.
Well, super informative. Any final advice for healthcare practitioners wanting to learn more about the pharmapreneurship space?
Yeah. So, what I was just mentioning about us being the most overtrained, underutilized profession is that if you're a healthcare practitioner out there and you want to engage a pharmacist, we are innovative, we are creative, we are ready to go. We just want to be included in the healthcare team. We've been singing from the rooftops or shouting from the rooftops for so long that we are the medication experts, and that is 100% the truth. But because it's not always easy to justify our income with reimbursement from third-party insurances, it can be difficult to intertwine us in the healthcare team just because of revenue streams and things like that. But if you want to engage your pharmacist, or every pharmacist out there has already concocted a business model in their head of how they can be incorporated into this interdisciplinary team. We're ready, we're eager, we're ready to jump when you say how high. There's many of us that feel that we do not practice to the top of our license, and we're so desiring to do so.
Well, let's see what we can do about that. And lot of bridging to do, it sounds like. But this has been super informative. Is there anything else? We talked a little bit about side gigs. That's something that we talk about a lot on this healthcare podcast, the TechLink Health podcast, because we don't just do one thing anymore, none of us. And I know you've gotten into a lot of consulting and things like that. Anything you want to add before we sort of have to wrap this up? It's been amazing, and plan our next 10 conversations with you.
Yeah, I myself have what I would consider to be a side gig with a psychiatric nurse practitioner company that primarily practices in the long-term care, senior care space. So they have taken it upon themselves to say, you know what, Kaylee's knowledge of psychotropic medications is so valuable that we're going to pay her either per interaction with one of our NPs or, a monthly stipend for open access to consult her based for patient cases, for regulatory compliance questions, things like that. Because long-term care is the most regulated industry in the United States, there's so much red tape and regulation that goes through that. So yeah, as far as I go, I am an independent consultant, kind of bringing it back to our first conversation. I am my own LLC. And there's plenty of us out there doing this exact same thing. We might even have a 9-to-5 job and then have our own LLC on the side. So if there is anybody that wants to engage us for our expertise, definitely there's so much room for side gigs and side hustles. Absolutely.
Awesome. Well, thank you so much for joining us today and really bringing a lot of interesting information that I didn't know about in the pharmaceutical space to light. And we just really enjoyed having you. And I'm sure people can reach out on LinkedIn and find you, Kaylee.
They certainly can. Thank you so much for having me. Yes, my last name with that tricky H is Mehlman. But yes, I am on LinkedIn. So yeah, feel free to reach out.
Thank you.
Thanks for listening to this episode. TechLink Health is a healthcare advisory platform for consumers and organizations to stay informed with the latest insights while connecting with healthcare experts for telehealth, e-consults, and consulting services. For more details, visit www.techlink.health.